morning, everyone. Today's first case is a 53-year-old female. She is a known hypertensive, presented to us with unstable angina, having normal LVF of around 60%. Her angiography revealed normal right coronary artery. Mid-LAD having a bifurcation lesion, including diagonal, Medina 110, and LCX having stenosis of around 95%. So plan is LAD bifurcation plasty and LCX plasty. Now we go live. Thank you.
Moderators are Dr. Louis Guzman, Dr. Takwan, Dr. Jayesh Rawal, Dr. Nitin Kabra, Dr. Ajay Mahajan, and Dr. Prakash Parikh.
Good morning, everybody. I'm here with a terrific team at Apex Heart Institute. We are about to do this two-vessel intervention. My live commentators are Dr. Samirio Patel. No, Patel, Dr. Samirio Pancholi.
Yeah.
And we have Dr. Fasila Malik from Bangladesh, and then we have Dr. Akasaka Sensei, who's going to help us with, so we have combo technique. Is that the regular routine way of taking catheters up?
Yes.
Okay, so regular wire, combo technique.
Good morning, Mauricio. Can you hear us? Just to make sure that...
Where is the pedals?
Yeah. Just
Can you guys hear us?
Yes, we can hear you well, Luis.
Okay, perfect. All right, we haven't seen the fluoro images or the angio.
Oh, you haven't seen? So it's a two-vessel. So there's a little bit of a complexity to the LAD, and then there's a simple lesion in the circumflex. The LAD and the circ have separate ostia.
okay.
So we'll have to see how we engage maybe we're engaged already. Okay.
Is wall touch? Oh, yes.
Perfect. Okay,
It's,
so we can,
selective,
I mean,
sir.
that's selective. We can take a cine there, so in
Epicaudal.
epicaudal for the circumflex, and then hopefully we'll be able to engage the LAD. I would like to start with the LAD first.
Take a picture. Oh,
So which guiding catheter do you have?
So this is an EBU 3.5, so I
it's
think
And you are going from the right radial.
we're going from the right radial, and this is a 6 French. We have a slender sheath.
So probably because it's a 3.5,
Let's
it
go a
goes a
little
little
bit
more
earlier.
biased to the circumflex.
Maybe it's a little bit short. Okay.
no. Take it yellow code.
LAO, a little bit of LAO caudal.
Ah,
So, Maurice, talk here. So which vessel you start first?
I'd like to start the LAD first because it's
Oh, it's
it's more
near,
complex.
near.
It's very near.
ah,
Okay,
you are
there
in.
we go. So we can do epicranial view first. Steep epicranial. Ready?
Yeah. That's good.
So we have a run-through wire. So what the panel feels? I don't feel, I don't really need it. I think in my
run-through.
practice, I would not probably,
BMW.
I would probably not wire the diagonal. Maybe I'm a little bit more cautious today.
So you have a kind of a Medina 101. The diagonal does not
Yeah.
appear to have a significant lesion.
So what do the panels say? Would you wire it or not? So I don't know if you can see.
Well, I see that. I think I will wide it. I don't think
That-
so.
so
Really
it's
complex.
the
Just to put a wire in the
this
diagonal.
So I put a double bend. I like to put double bends on the wires. So we're going to take the wire up.
So personally, I have the concept always like a radialist minimalistic approach. I have the concept of keep it simple. So in general, unless there is a significant stenosis in the side branch, I do not wire the side branch. I use a single wire, which I would have used in this one, but I would have no problem if you consider that you have to protect the side branch. I do not think that will be a problem in this case.
I think that for today, I think we are going to use another wire. And we're going to protect. I think that was a consensus when we planned for the case, so we will stay on plan. So let's see if we can put a towel. So for the wires not to mix, I would like to put a towel here on top of this
Maurice,
wire.
are you planning to do imaging first?
We are planning. I'm not entirely sure if the OCT, we have Akasaka sensei here. So,
Okay.
so this BMW, so the first wire was a run through. It worked incredibly well, as you could see. Now we have a preformed BMW.
So yes or no? OCT,
OCT, yes. OCT, yes. Maybe pre-dilate first, and then OCT before stenting, so we can size the vessel and see the side branch and get additional detail that we can all learn from Dr. Akasaka.
Dr. Akasaka, would you put a second wire in the diagonal, or in this case?
If we have an image before the intervention, we can speculate the compromise of the side branch. There are only one report by OCT. We try to measure the start of the side branch and the length of the side branch and the tip of the carina. If it is more than 1.7 centimeter, there are no risk to compromise the side branch. And also we try to check the carina tip angle by OCT longitudinal view. If it is less than 50 degree, there might have a risk of the side branch compromise.
The
So
big difference between this BMW wire and the run through, and then this is a preformed.
Yes.
This is a preformed tip.
So from the OCT, we can predict the side branch closure. That's what it said.
Yes,
Okay.
that's right, that's right.
So the 1.7 millimeters is what you're saying, or because you say
Yeah.
1.7 centimeters?
1.7 millimeter, right? Yes,
Okay,
millimeter,
okay.
right.
So, Akasaka sensei, shall we pre-dilate first with the 2 millimeter
Yeah,
balloon?
if you try to get a clear image, you can do the pre-dilatation. But I think in this case, we can obtain a good image without pre-dilatation.
Okay, let's do OCT then. So we turn the towel here. We turn we just fold the towel and we separate the wires. So that's a nice thing about this.
In selective LAD or not? Just check it. It's. Oh no. Oh yes.
And
That's
pre-dilatation
fine.
could have caused some plaque shifting into the diagonal.
Yes,
So
yes.
we want to see
Yeah.
how the diagonal
That's
is.
So the
right.
guide now we
without
have
any
a very good and selective cannulation of the guide, which is crucial for the OCT.
Is that a 6 French or a 7 French?
This is 6 French.
And your sheath is a slender 6/7, correct?
Exact. Yeah, correct. This is an amazing setup in this cath lab, and it's impossible not to feel very, very comfortable and like at home in this setup. Wires come back a little bit. Yeah, we'll have to cannulate a little bit better. Just give me a little bit more slack.
Yes, I think for the beginner, I try to explain the catheter. There are 3 markers. One is the
Okay.
tip
I think that we're in good shape there.
tip marker, and then the second marker is the lens marker, we can obtain the image at the lens marker position, and then proximal is an 5 centimeter
About there.
proximal from the lens
You
marker.
comfortable with that?
And
So
yeah,
she may get a little
we
bit
can
ischemic
decide.
because
And
the system is so
length,
close.
so
Yeah.
Okay, you just let me know when to.
yeah, 7.4, right? Yeah.
Did you?
No,
did you-
7.5 because
Yes. Yeah. Already.
yeah,
Okay.
yeah, today, yes. After putting a stent,
Perfect.
5 point.
Yes. 1 meter.
Let me know when to see it.
There are 2 pullback lengths.
Okay.
Yeah,
Fluoro.
okay.
Yes, KJ. It's already done. Not moving.
No, because the catheter is occlusive.
No,
You can
that's
take out
a
the
little
side branch
bit
wire,
delay,
then
so
it is possible.
yeah.
Then it will
Check
move.
it. Its diode is there.
They are
or not.
using
Diode
the
is
auto
there or
pullback system. Then I
Diode
try
is
to
there or not?
recommend.
Yeah, there is
the-
die.
Oh no.
No,
Okay, that's fine.
pre-dilation. Yeah, much more
Let's do
good image.
pre-dilatation, right?
Yeah, thank you.
Yeah. So the catheter was occlusive, so
So you pre-dilate it first.
you're going
Yeah,
to pre-dilate.
yeah.
Can we take out the side branch wire? Then it is possible to. Then it will not be that much occlusive.
There are two ways to obtain the image. One is a manual, one is an auto
215
pullback,
balloon?
right? The sensor
we have a 215
catch
balloon
the
ready.
contrast, but in this
And
case, the stenosis is a little bit significant. So the cleanup, the lumen is a little bit delay. So auto pullback system, it might be very difficult to
That's
catch
okay.
up the pullback point, right?
While they pre-dilated, Dr. Akasaka, can you tell us a little bit about non-conscious OCT? What you can use?
Yes, in our institution and also in Japan, the low molecular dextran, yes, 10% lactate low molecular dextran is very common to obtain the image without contrast. And it is okay in the daily clinical practice. And there someone tried to use some saline, but the saline is sometimes difficult in the left coronary system to obtain a clear image. And yes, if there are, in this case, we have a side branch guide wire, so we can do the PCI without any contrast. If you use low molecular dextran, we can measure the length of the lesion from the marker of the side branch guide wire. It's quite easy. And if you want to have an angio co-registration, we try to put the contrast within the guiding catheter and then try to use the low molecular dextran, only 1 or 2 cc contrast, make angiography, and then we can take a good angio co-registration if you want. There are some tips and tricks, yes.
So basically, you fill up the guiding catheter with contrast, and then you inject the dextran after that.
Yeah, yes. At that time, we can obtain the angio, only 1 or 2 cc contrast, and then we can do the angio co-registration if we want. Right. Actually, angio co-registration is very useful to do the PCI because anyway, we need an angio when you put a stent, right?
Yes.
So it is very useful technique, right?
So has there been any study with the dextran comparing to with contrast, and does this dextran compromise the images that we get?
There are only one report we did compared with dextran versus contrast. There are no significant difference, but the only one report showing the correct measurement. Yes. Basically, light penetration is a little bit different in contrast and dextran, but clinically not so significant. We can use a dextran in daily clinical practice.
Okay.
Okay.
So that
All
would be
ready?
a great thing for CKD patients.
Yes, yes, that's right.
Just check it once. Oh, it's too hard.
Too hard?
Yeah, inject is too hard. Okay, okay. Yes.
Let's see if we're in the puff. Just a quick puff.
Oh, it's not
Guiding
proper.
catheter position.
Wait, wait.
Yeah, right. Little bit.
Puff there again.
Yes,
Yeah.
yes, perfect.
No,
Yes.
Okay. Ready?
Fluoro. It's okay, fine.
Yes, yes, yes. Okay,
All right.
good.
Oh, it's come very late.
Good, very good. Okay, yeah, take out the catheter. I try to explain.
catheter
Yeah,
back.
yeah, yes. Very wonderful image.
It
It could not be other way with the team that I have here.
Can you see the OCT image?
yes.
Okay. So
we remove
try
this
to
catheter?
check.
Yes.
Yeah, I always check. We cannot see the, in this case, very short left main, so we are not sure. Here might be the
It's a
CX,
separate origin.
I think. Then try to move here because the upper side is an epicardial side and here is a myocardial side, right? Then try to check the diagonal first. You can see the two wires, right? Here, right? And then still two wires, right? And here one wire goes,
One wire
right?
goes away.
Here is a
Yeah.
diagonal, right?
And there's no
Then-
disease whatsoever there, right?
Right. So we try to check here, right? Here is a diagonal. You can understand, right? Quite easy, right? And then, as I told you, I try to check the right, the length from the tip, right? Here is a 2.6 millimeter, right? From
So-
so and also you can try to measure this angle, the tip angle, right? More than 50 degree is very important. How to measure? We have no measurement system, but it's quite easy to speculate. You can understand the 90 degree, and the mid portion is 45, right? If it is the 45, less than 45, it's some risk. But here might be the almost 45 degree. So from the angle, some risk if you dilate more. But I think the length is enough. So there are no risk of the side branch compromisation.
Correct.
Right? Yeah.
So I would leave the wire there. So if the panel agrees, I'll leave the wire there. Then we will do a stent. I think, what do you think? 2 to 5 stent?
Okay. I'm sorry. I tried to check.
Yeah, let's see. Because
Yeah.
the 2O balloon looked already well sized. So I
Right.
think we should go with the 2 to
The-
5 stent and we can post-dilate the proximal part.
Yeah, distal portion is and the lumen is 1.8. You can take 2 millimeter. Yeah, right.
Okay.
Wait, and then how to put the stent in the proximal? Here is
And proximal, it should be 275 to 3.
still there are lots of
Not 3,
here,
huh?
here might be the idea, but too long, right? 36 ideal portion, but how to put the stent?
If you are taking 2.25,
There, right there.
then inflate only at 10 atmosphere, pull it back and go at high pressure. Otherwise, you will dissect distally.
Correct.
If you
So-
take 2 millimeter, you can go up to 20.
Yeah, well, let's do
In
the
this
2
case,
to
we
5.
go for a 2.25.
Let's
2.25.
2 to 5.
See, actually,
By 30.
you know, we do this type of cases and we evaluate OCT and then we correlate. If I were you, I will take a 2 millimeter balloon and go at 18 atmosphere and you will see negative residual distally.
Okay.
2 millimeter stent.
2 millimeter stent.
Yes.
And length, we should probably do a 30 millimeter or
That's
26.
fine.
30
And then
millimeter,
you can
right?
post dilate whatever, no problem.
Yeah,
It
let's
can go up
let's
to
run the
3.2.
image. Let's run. Yeah. Yeah,
Yeah.
30 millimeter, 2O by 30.
2O by
30, and then we can post-dilate the proximal part with a 275 or a 30.
that's fine. So 2 by
So the
what
so the
length you want?
2.0 will go up to 3.0.
3.25.
So that's
Louis,
wonderful,
it
right?
can go up to 3.25.
I see.
Because it is onyx, yeah.
And then the proximal diameter of the vessel, proximal to the diagonal, is what's the reference there?
Is 2.85.
2.85.
Yeah,
Okay,
2.8.
so we can crank up a balloon there, and I think it will look beautiful
What length?
with preservation of the two branches.
2 by longest. Get, please. It is very funny to take 2 millimeter stent, you know.
Yes,
But it
especially
works
in the
these
middle
arteries.
idea, you know, by rule, I never do a 3.5, less than a 3.5 stent in the LAD.
Well, in the proximal.
In the proximal mid LAD, mid proximal LAD, I never do less than 3.5.
Yeah, there are lots of stent sizing. Someone recommend EEL, but try to think about the final diameter of the stent. And if you select a bigger stent, try to put a stent in within a nominal pressure to avoid.
Mauricio, we have 2 by 30, but 2.25 we have a long stent. If you are taking 2.25, you know, it is good to inflate up to 10 atmosphere only and pull it back.
We already taken
They've taken a
230.
2 already.
230 already taken.
230. Okay.
230, yeah, perfect. So we can go with this, we can go to 15.
Yeah, as I told you, if you select the bigger stent, try to put a stent with less than nominal pressure
Yes.
to avoid the distal dissection, and then dilate the proximal.
Exactly.
We can do that too, yeah, that's actually always good practice.
Actually, you are doing a proximal optimization as well as a better stent deployment.
And sometimes when I have a larger size stent and I don't even go to nominal pressure.
No.
Maybe I go to 6,
Yeah.
then,
Yeah.
then the second time I go to 8,
Yeah.
and very, very gently,
Yeah.
and then I slightly pull back and then go to the nominal pressure.
That's right. That's right.
So being gentle with these vessels, especially this in this region, the vessels seem to be very, you know, receptive to dissection. So you
Yeah.
have to be extra gentle.
Yes. Yes.
Take a picture.
Okay, let's take a picture.
That's
I
fine.
like that.
Looks pretty good to me.
I like that.
Okay,
Yeah,
that's
I
good.
think proximally looks perfect. So when the vessel starts to taper, and I think distally we
go
are
up?
covering it. Yeah, go up.
This 12.
Yes, certainly the
You're gonna go a little
magnification
bit
trick
li-
us
bigger,
because I would have never
14,
thought that this is a
16,
2.0, but
There's a
Yeah.
2.0 stand.
This is a 2.0
Yeah.
stent.
Looks big here.
Yeah. Deflect.
Perfect. Come down.
Take little back and go in high
We
pressure.
see so many cases in these couple days, Dr. Akasaka.
Yes.
I haven't
let's
seen a
go back
lot of positive remodeling. What do you think?
Yes, yes. Here in the proximal side looks very normal, right?
Yeah.
It's
Yeah,
okay.
up there.
But the distal side, there are lots of fibrolipidic, and
proximal.
here we
Two
can
proximal?
identify the calcium, right? Very complex region.
Okay.
There.
Okay. Okay.
But distal here already dissection by the balloon dilatation.
Yes.
But here might be the ideal
Okay,
portion.
so let's get a
Looks,
275
very,
by,
fibrous, right?
I would say 15 balloon
Yeah.
or 18
So there's
balloon.
no remodeling.
15, I think. 275 by 15.
so this balloon has to be very compliant
Yeah.
because
The other thing that worries me is because it's a single osteum LAD, I'm worried when I'm sucking in the guide. I mean, these vessels are so friable. I have to remind myself that I'm dealing with Indian coronaries.
how hard did you go here? Just 10?
No, we went to 20 because we pull back. If you can tell that balloon has very short shoulders, and we pulled it back, so to avoid the dissection of the distal edge, and we went up to 20.
Louis, he inflated at 10 atmosphere, you rightly said, and little bit pull, and 20.
Any
2.75 by 15. Yeah, get NC track.
Okay, perfect.
You want to check the result? You checked it?
So you can see here how the stent, how the balloon is pushing the stent towards the side branch very well.
Look here, negative residual distally with 2 also at 10 atmosphere.
Yeah, there's a step up, yes. Yes,
I'm
yes,
glad that
yes.
you didn't put a 225.
So this is our artery. 2 millimeter negative residue.
Same inch.
Maurice, is this the first 2O stent you put in LAD?
I'm sorry, repeat the question, please.
Is
It was
this
a
is
joke.
the first 2O stent you put in an LED?
I think so. No, it's not a joke. I think it is. I usually do the 2 O's I do in PDAs or distal OMs.
Tak, if it was a 2.5 stent, you know, you could have created another stent distally or intramural hematoma in this artery.
Maybe you are used to doing that in Chinatown cardiology.
Tak, do you use 2 millimeter in your Chinese population who come to you?
The Chinese population, yes.
Yeah.
Yeah.
Are you using 2 millimeter just like
No,
Indian
no.
artery?
No, I think our artery is a little bit bigger.
A little bigger, huh?
I like that.
Yeah.
Not as big as a
I mean,
Maurice.
the definition of this angiogram and the visibility of the stents is just incredible.
We go little distance.
Yeah, it looked like you
After
were
that
doing
one,
a
it's okay.
stem base there, or stem boost.
No, there's no stem boost. I mean, it's amazing.
No, I understand that. Yeah, but the quality is so
Yeah.
good that it appears to be a stem boost.
I have to be careful. I'm retracting the guide because the guide is sucking in here. So I'm pulling the...
This big screen, Louis, you know, eliminates a lot of visual fatigue, believe me. And after doing 15-20 cases, if you confront with a complex case, you know, it is good to
So we can.
visualize
So
on a
what
big
I'm going
screen.
to do next, I'm going to pull the side branch wire, and now we are going to proceed to repeat the OCT and hopefully get good feedback from Akasaka Sensei.
Yeah, initially we pull back 74 millimeter. It's a screening of the vessel, but after putting a stent, we can focus the stent, yes, a little bit distal and proximal. Then we try to decide to use an 54 millimeter pullback. The frame rate is a little bit higher and the image should be better.
Just a question to you, Dr. Akasaka.
Yes, yes.
If someone, a beginner wants to learn OCT, right?
Yes, yes.
So obviously he has to do practical cases and all. But which textbook would you recommend them to read? Is there a good book on OCT?
Yes, there are several books. Yes, I.K. Jan already wrote, and we are doing, we wrote the Topol textbook. We have some chapter of OCT. Okay.
I think for beginners, yesterday's Dr. Patel's talk is enough to start.
Absolutely, absolutely, yes. That's what I feel. That was fantastic. And I wish we, I've already asked him to give me a hard copy or a soft copy of that.
That's nice, huh?
That's right.
Okay.
Chalo.
It's okay.
Yes.
So, yes.
It's came
Hello.
out.
No, it's come
Wait,
out.
wait.
You're not.
Sir, I'm having one question.
There you go.
What we did is we put the two
Distal,
stent
we go
and
little
then
distal.
we did the pull
Little
back.
distal.
Yeah,
we go.
I need to go a little bit this.
I'm here, sir. I'm Dr.
Okay.
Dheeraj. Yeah.
No,
I'm having one.
no,
one
to
question.
this, it's
We're not
okay
engaged.
because we
What
cannot
we
see
did
the.
Okay.
Ready?
Little proximal.
Huh?
Little proximal.
I'm having one question to Dr. Akasaka.
Please.
Okay. Okay.
We put 2 stent and then we did
Chalo.
at minimal atmosphere of 10
Fluoro.
and then we pulled back it and we did with the maximum we went 20 atmosphere. Is it
Now-
like that?
Yes. It,
But is there any chance
Not
of
pull out.
proximal end endothelial damage and that can give inflow stenosis in the future?
is not
We
came
should
out.
be scared for that, or
Yeah, if there are, yes, landing zone is lipidic, there are risk of an
Okay. One more?
HD stenosis.
Distal wire is okay.
Wait a moment. We are now just focusing on the OCT detection. I will answer
Yes.
later. Yes.
Yes, ready?
Yes, yes.
All right.
Yes, yes.
Okay, thank you. So, the landing zone tissue is very important. By IVAS, there are recommendation plaque area should be less than 50%, right? As you know very well. And by OCT, we can see is the landing zone the lipidic or not. In this case, yes, we are trying to put the fibrous plaque portion, right? And then here, try to check the landing zone. Only a small amount of dissection, right? You can see here.
Yes.
But this is less than 60 degree, right? I think. Are there any yes, answer to the degree of the dissection? This is limited within intima. So, and the length should be, I try to measure here, right? It's already disappeared. Then length is from the distal portion, right? I'm sorry. So only 0.8 millimeter. So we can leave it alone, right? No problem. The very small amount of dissection. And then try to check everything, right? From here to the okay. Position is very
And
good.
there you have the bifurcation.
Yes, yes. So I put the bifurcation, yes, here. Right. And then all opposition is very good, right? Only proximal, some incomplete opposition here, right? Yeah, yeah, small amount. You can see that here is the color bar demonstrating the opposition indicator. This indicates yellow, right? That might end around 200 micron. Yeah. And this red color demonstrate 300 micron. So we try to, yes, dilate in the proximal side a little bit.
We can touch that up with this short 3O balloon. Is that 3O there? The diameter?
Only taken 2.75.
We can do. We
But
can
we
use the same
dilated with
balloon.
2.75.
Yeah, we'll do
Yeah,
that.
We do again, no problem.
probably it's because you didn't touch it. It's not because the balloon was smaller.
But,
Little bit,
but
yes.
Dr. Akasaka, don't you think that dissection which is confined to intima will extend to media in that area? Just a thought.
And the distal one, the problem is that distal is so small.
No, not here, yeah, that's fine.
No.
The distal dissection is, I
That's
mean,
fine,
the vessel gets so small that you're
That's
going to
fine,
start
yes,
chasing
yes,
yourself
yes,
if you try to do something to that. So, as Dr. Akasaka said, that it's an intimal dissection, it's very short,
Yeah.
and the angle that involves is very small.
See, here, why the expansion is 67%?
Right,
That is a
yeah.
problem.
No, this might be the, right, here might be the under expansion.
You're going
I
to take a
understand.
picture of this?
Little proximal.
I
This
think
is
it looks good
It's
there.
a- looks good, I
limitation
think.
of the soft
Yeah, I think it
That's-
looks
that's-
good.
that's the
Let's go up
reason
there.
sometimes.
Yeah.
Does it make any difference if we put it on a tapered reference because the artery
that's
looks
good. Okay.
Perfect. I think we're done here.
yeah, display.
That's fine.
Hang on one second. So, are we going to take a final angiogram without the wire?
Yeah. Yeah. And tapered. Okay, yeah.
Just don't want to lose
It is 67,
Up there?
so it doesn't make much difference. But fine, it's okay.
Okay.
Hang on one sec.
Here is another.
But Dr. Akasaka, what initially was perceived like 90%
fantastic.
accepted is now 80, right?
80, yes, yes.
And 80 means like somewhere here it is 76, somewhere here it is 82, we can leave it alone.
Yes, because even in a tapered method, after the big branch, the diameter changed suddenly. For example, here is a diagonal branch, and then we put here, it's a perfect result, right? Then
that's right.
we try to move another big branch.
LO.
Here is a septal branch, and then move to the little bit proximal to the diagonal branch here. At that time, a little bit under expansion.
Yeah, that was something that I wanted to comment, Dr. Akasaka, because we are the software. When we see everything white, we say that it's wonderful. But we don't have to forget about the stent expansion and the area.
That's right.
So even though it's well opposed, might not be well expanded. So probably right there, just before the bifurcation, person I think is a little bit underexpanded.
Yeah, I agree.
And Louis, I as an interventional cardiologist who is involved with OCT imaging, I personally feel that apposition is less of the enemy, mal-apposition rather than under expansion.
I agree with that. There's good data from Korea saying that, especially in the left main, that malapposition is not as bad as under expansion and D-shaped stents. Okay, so let's. Do you wanna post-dilate with this?
Yes, this 7.7.
Pre-dilate with this. This is 275.
Yeah,
Let's use this to pre-dilate.
Please take it out. Okay.
Are you sure that we don't want to use this to pre-dilate? This is a 15.
It's okay, fine.
So we're going to use a little bit of economics here, and hopefully we'll be able to advance this.
Yes.
Something.
Okay.
So using a little bit of economics, we're going to pre-dilate with a 275 balloon we used to post-dilate the stent.
Okay, that's fine.
And now we should probably do another.
So before you do the OCT here, you notice that the artery has a diffuse disease after the tight lesion, and certainly the OCT is going to show you a lot of plaque in there. So are you planning to cover the entire length of the plaque, or you're trying to just do a little bit more of the
Let's do the road mapping. Let's show the angiogram again. Let's go back to the first picture. First picture, and let's set up a roadmap. I mean, Luis, I don't think that.
That is pretty good. Yeah, it was probably.
I think it's pretty good. I think it's a discrete lesion. It's a type A lesion, probably 10 millimeters in length, and the 15 millimeter balloon actually looked very, in terms of distance, looked very good. At the most, I would place an 1830 by 18 stent.
Yeah, there might have been some spasm or something like that.
But we're going to do the OCT first, and we're going to size the vessel accordingly.
Okay. Yeah. During their preparing, I try to show the OCT previous the bifurcation lesion. Yeah, here is the big diagonal. Can you see the OCT image?
Yes, we can, and we are looking forward to for you to tell us how is the predictability to cross distally versus proximally in what you're showing us.
Right. Here is the bifurcation. Can you see? Right?
Yes.
Yes. And here is the big diagonal, right? Here. And here is an strut, right? And there are some overhanging, right? If you try to do the kissing balloon, try to select this cell, right? And then do the kissing, and at that time this
yes, we are ready.
Strut
we're ready here.
Goes to the attached to the proximal side of the side branch. It's the best way to avoid. Yes, we try to see the new OCT image.
Check it
right?
once. Easy. Oh, it's okay. Chalo, yes, ready?
Okay. Wait a moment.
That's fantastic.
Okay, this is an OCT image in CX, right?
Yes.
Yeah.
The vessel looks pretty good distally, yeah?
Yeah. The very, yes, almost normal looking in the distal side,
yes.
right? And here is a lesion after a pre-dilatation. Then, okay, it's a proximal site. So try to identify the landing zone, right? The biggest diameter should be around here, 2.5, around 2 point, right? And then try to see the proximal landing zone. Yeah, here is a wonderful portion, right? Yeah, also the acceptable.
It's 2.7.
Yeah. Right. So the distal diameter is
2.43.
Yeah, right. Distal is 2.4 or 2.5, right?
Yeah.
Yeah. And proximal is 2.9. So you can select the 3. If you select the 3, try to put it very gently.
Okay.
Okay,
Yeah.
let's do that. And then we can retract.
Take out and then
go up, go back up.
So 3018?
3018.
His length is?
3018.
18, wait a moment.
18 should be good.
Here is an 18, right? 18 is okay.
Is okay.
Yeah, 18 is good. Yeah.
Yes.
Chalo, 3018.
Any additional comments there from the panel?
Why not 2.5, 18 and then post-dilatation with 3?
2.5, 18 all right. If you dilate the proximally in using a bigger balloon, it's okay. So I just want to say the stent siding is the one, very important issue, but not so big because we can control by after putting a stent or using a ideal pressure, right? So the final diameter, I'm not sure, the 2.5, it might be 3 or 3.5, right? So we can control, right?
Yes.
Yes.
So actually the comment that one of the persons here was comment, I don't think we addressed it properly. So his question was, and I'm a little bit also concerned about this. So when you put a smaller stent and then you post-dilate it with the same stent balloon at higher pressure, that the size can increase by 0.2 or 0.3 or even 0.4, depending on the stent that you're using. His question was whether you are concerned about producing any damage in the normal artery above the stent, and I think it's a fair concern. I do not know if I would be that aggressive and too much outside of the stent, because certainly you can increase risk stenosis by doing that.
18.
Yeah, I understand what you want to say. So the ideal way in this case is select the 2.75 stent and put it gently and take out and using a higher pressure to get a good position in the proximal site. That might be the very ideal based on the OCT recommendation. But if you try to select 3.0, it might be okay because we can change the diameter using a different pressure, right? So try to avoid. I think avoid the distal damage is most important, because if there are lots of damage, we try to put a stent in the distal, right? Additional stent. But proximal, much more proximal, the diameter is much bigger, right? So the balloon should, here is a 3.20, right? So 3.0 balloon dilatation should be okay. It is based on the OCT image. Here is an actually 2.9, right? But here is just after the proximal edge, 3.2. So balloon should be, if even balloon becomes 3.2, it might be very safe, right?
Okay.
Dr. Akasaka, does the intracorner nitro help here in sizing the stent and all?
Just
after
check
pre-dilation,
it
do
once.
we give intracorner nitro and?
Okay. Yes.
I cannot hear clearly. I'm sorry.
Does intracoronary nitroglycerin help in sizing the stent in this type of situations?
Yes, to avoid the spasm, yes.
Yeah.
We can
Sizing the stent proper diameter and all.
Yes, yes. I agree.
Fluoro.
Good image.
Angiographic looks pretty good also.
Yes, and OCT image also very good. Okay. Can you see the OCT image?
Yes.
Oh, it
right?
looks nice.
I try to check the distal landing zone, right? Here is in the distal landing zone and a little bit distal to the edge. There are no damage, right?
Yeah.
Very wonderful, right? And then try to check the proximal site, right? Our position is
It's
very
perfect
good.
apposition.
Yeah. And also
And there's
no
no
damage in the proximal site. And the expansion is 80, right?
So do you think we should post-dilate in the middle to a bigger size, or you're happy with that?
If I'm very happy, but if you want, try to dilate this portion a little bit, because here is...
Yeah, I agree with that.
Right?
So what was the area there? If you want to measure the area, what's the area?
Let's get
area, right?
a 3.0 by 8.
Here?
Yeah, short, non-compliant.
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 All right, I'm sorry, right? Okay.
So we're going to go with a 3.0 non-compliant balloon.
Yeah.
The area
just
is
to
5?
post-dilate.
So whenever it's more than 4.5, we know
Yeah.
that the restenosis is lower.
But here is the MLA site, right? 4 point, yes, more than 4.5, yes. So as I told you, I'm okay if they stop, but compared with an proximal reference and distal reference, expansion is 77. If you want to
308.
yes,
308 is
improve the more than 80, you
Yes.
try to dilate here, right? It's depend on the tissue, right? Here
Yes.
is fibrolipidic and no calcium, so there are some possibility to dilate a little bit more, right?
Take it
If
up
you
to
dilate
16.
using a higher
Yeah.
pressure, right?
Is okay.
And
Yes.
if there are a very
it's minimal, the
eccentric
growth is
calcium and
minimal.
the opposite side is completely normal, there are high risk of the perforation because
Need my
the
glasses.
stent expand normal site, right?
Yes.
So it is really an image guide PCI, right? But
Very, very, very insightful. Really very insightful. I think if we measure the area on that LAD, I think it's less than 4.5 expansion. So that was my concern in that one.
Yes, but it depends on the vessel size, right?
Yes.
Yeah, so we always take into account the percent diameter stenosis and also the minimum lumen area. If both are acceptable, we can stop,
Do 2.
right?
Yeah, go up to 18. That's
Take
good.
it up. Yeah. So we're gonna do 2 inflations. What I was thinking is that how unlikely that an Argentinian will be moderating from the classroom and another Argentinian would be doing the case.
It's a small world, right?
Yeah, it's the Argentinian.
Yes. And both in Ahmedabad.
Yeah, the Argentinian invasion of India. I think it looks magnificent there.
Yeah.
I think we.
Outstanding.
Remove your
Yeah, I think we can pull the wire. We can take a final picture, make sure that we didn't do any damage there with.
That's fantastic.
Looks great.
Looks really nice. I'm very pleased with the case. So we're going to pull the...
And very educational. I think even though a type A lesion provides a tremendous amount of education.
Radial band device. You saw it? You saw the radial band device?
No, we can do it.
Thank you. That was very...
Okay. Thank you so much. A privilege.
All right,
to work in this
congratulations for a
laboratory.
great job.
Thank you.
Thank you.
Thank you.
Let's use the band.